start the March 13th Monterey County EMS Emergency Medical Care Committee. We'll go ahead and we'll start with the roll call and introduction.
All right, roll call. Good morning. Glad to have you all here. Okay, Will Hiller.
He's absent and
Absent.
I'm in his place today.
Okay, Sam Clemic.
Here.
Perfect. Harry Robbins.
Here.
Jody Schaefer.
Here.
And I'm going to say hi to Nancy.
I'm right here.
Oh, we moved over there.
Yeah.
Okay. You want to share or shall I?
I unfortunately, my seat here on EMCC was short but sweet, because I've taken a position with Greenfield Fire, part-time position, so I can no longer be the citizen rep for South County.
Due to an affiliation with a constituent group, she can't be a citizen rep, it has to be unaffiliated. So
Yes.
Nancy, we do want to thank you for your short time of service
Short and
again,
sweet.
because you were on EMCC years ago.
Right.
But we're glad that you're still part of the system,
I will definitely continue to be part of the meeting, so, yeah.
so thank you.
Thank you.
Paul Wood? Here. Dr. Greenson, as I think we mentioned, tendered his resignation. He's spent a number of years, so we are also, in addition to looking for a citizen rep, we are looking for a physician rep, Spencer Harnett. Carla Spencer,
Here, good morning.
Jeff Watkins.
That's gonna be me.
Yep, we'll get
I'm the
to
new
that.
Jeff Watkins.
Yeah, we'll be making something with the law too. John Anthony,
Here.
perfect. Ex officio members, Kelsey Scanlon, Teresa Rios,
Here.
Leanne Magoski.
Here.
You moved too.
I don't want to leave Sam on the side of the table by himself.
Okay, alternates, Michael Esslinger.
I'm here.
Let's see, we don't need, let's see. Johnny Mike DeLeo, Cheryl Getz, we don't need. Dr. Hawthorne. Joe Cafaro. Chris Borkin.
Here.
Oh, there's Joe. Yep, there you are. Perfect.
Yes.
Chris Borkman
Here.
and Bandy Smith. Okay, we do have a quorum.
Excellent. We're going to open it up to public comment.
Oh, sorry. Do any guests would like to introduce themselves? It's not a requirement, but unless you want to speak on an item, then you have to introduce yourself at that point. Anybody online want to introduce themselves?
Will Hiller,
Gavin
AM
has their hand up.
Operations. So sorry, I have sick children at home today, so I can't make it, but thank you.
Okay,
Michelle Kalinsky, Shop. Melanie Rhodes, Monterey County Behavioral Health.
Clayton Brown, Active Transport.
We have one more. Hold on to their hand up.
Okay, seeing nobody else who wants to introduce themselves.
I think Eric Sine
Eric
with
Sine.
Freedom Medical Transport.
Yeah, Eric Sonny with Freedom Medical Transport. Can you hear me?
Yes, we can. Thank you.
Okay, very good.
Okay.
And nobody in the room wants to say, so, okay. You're good.
All right, moving on to public comment.
Anybody would like to speak on a matter not on the agenda? You got 3 minutes to do so. Eric, did you have a comment or is your hand still up just from?
I just lowered his hand.
Oh, perfect. Okay.
There you go.
Broke his arm.
Eric, would you like to comment on something that's not on the agenda? Not hearing anything. Okay,
Okay,
His hand keeps
I'm
popping
there,
up.
I'm there.
yes.
Yeah, just, we have put in a bid for behavioral health contract. So if you guys wanted to talk about that, we could for a minute, but other than that, we're just listening in.
Okay, well, thank you.
You're welcome.
Okay, I'm gonna just announce a quick adjustment to the agenda. We're gonna be moving item 6E up ahead to accommodate a speaker. And we're gonna do that right now. So we're gonna turn it over for behavioral health community crisis services, Deborah, and I guess you have a speaker as well.
Yeah, so I want to introduce Melanie Rhodes to the group. She's Deputy Director in the Behavioral Health Bureau of our Health Department. Amongst her many responsibilities are the home crisis services and specialty teams. So she's going to give us some information about their capabilities and services that they're offering throughout the county now. And then we'll provide some additional information after that on EMS agency guidance related to that. So Melanie, thank you for joining us today, and I'll turn it over to you.
Great, thank you, Kent, for having me, and hopefully everybody can see the screen.
Yes.
Perfect. Okay, so I just wanted to share a little bit about our expansion of mobile crisis services in the county. Some folks may know that we have had a version of mobile crisis services here in Monterey County since November of 2015. But per State Department of Healthcare Services requirements, we spent last year really figuring out how we could scale that up to meet our new 24/7 mandate for services. And so how we got here was, again, we had our behavioral health mobile crisis team that started back in 2015 when co-responder models were the way that mobile crisis was really operating. So our team started and was very attached to law enforcement and co-responded out at the request of law enforcement when calls came in through the 911 system. In July of 2020, we added on a contracted provider to provide specialized support for children and youth and their families. So that was Seneca Mobile Response Team was added in the middle of the pandemic shutdown. We stood up that service. And then last year, we really worked at building out to meet the mandate. And to do so, we contracted with another provider, Sierra Mental Wellness Group, who is, while new to Monterey County, is not new to providing crisis services and supports, as they've been operational in 4 or 5 other counties across the state in doing crisis work in the community and also in facilities. And so we partnered with them. And we stood up our new community crisis line as a 24/7 line to help us integrate with 988, because this line is answered by our regional 988 provider, which is Family Service Agency of the Central Coast. So part of the state mandate was also for behavioral health and county behavioral health facilities to figure out how to integrate and work closely with 988 and to figure out a pathway. So whether a call came in through 988 or a community crisis line or 911, that it could result in a mobile crisis dispatch out of a 2-person team if that was determined to be appropriate. So what we really had up until the end of last year, beginning of this year, was historically a system that was very tied to 911. Our team would get paged out through the CAD at law enforcement request, and things had to really be at that escalated, heightened level to result in a mobile crisis response out in the moment. What's new is adding that pathway for the community to call in sooner rather than later when folks are experiencing a behavioral health crisis. And as long as there are no weapons or immediate safety issues, then we have a mechanism in place on our end to be able to dispatch out one of our teams. And so it's a big partnership. So with not only behavioral health, but Seneca, Sierra Mental Wellness Group, 988, 911, And we also have a new pilot program for this year with the city of Salinas that we'll talk about a bit more in a second. So Sierra Mental Wellness Group, our new providers, are really doing a few different things for us. They are staffing up a 24/7 mobile crisis dispatch center. They are also staffing up a 2-person team for countywide mobile crisis response, as well as an additional 2-person team for our 40-hour-a-week pilot with the city of Salinas. And we're really working at integrating them with our behavioral health staff. They're based out of our buildings. They're responding out in county cars, our county behavioral health mobile crisis cars. And so we're really working side by side with them. For the city of Salinas, we have a special additional pilot project with them. The city has contributed some funds for that to enable us to staff up the additional 2-person team for the city. And our MOU with the city and the county was finalized back in December. And so we're really hoping that we can see what we can learn during the course of this year from our collaboration with them, because this is for the first time that mobile crisis would be able to be initiated by fire and not just a law enforcement request. And so we've done some training for City of Salinas Fire, completed that back in January. And then now we're really just looking at, how this being able to initiate a mobile crisis request, like under what sort of circumstances could this be a useful resource? So I just want to clarify that we have not expanded to responding to calls from fire or EMS agencies countywide. This is just specifically for the City of Salinas pilot. Here's a little bit of information on Seneca Children and Youth Mobile Response. And again, they specialize in serving populations up to the age of 21. They also specialize in working with current or former foster youth or system-involved youth. And they can provide sort of wraparound support for up to 30 days. So it's not just like a one and done service. It's more, it can be up to 30 days of follow-up and then linkage to ongoing services. So really for mobile crisis now in our county, we have a more integrated and layered approach. We've tried to break down some of the silos that existed previously. And having this mobile crisis dispatch hub separate and independent from 911 to be able to take some of these calls proactively. Our hope is that we can get the word out in the community that folks can call sooner rather than later. And then hopefully we can intervene before things get to really that crisis emergency level of needing 911 response. So we're still responding to calls that come through 911, but we've also created this new pathway to hopefully head it off before it gets there. And so this is just a little bit about what mobile crisis services are, what they can do, how they can be helpful. And really, when we're talking about behavioral health crisis, we're talking about crisis due to either mental health or substance use or both. So not all social work is the same. Mental health and clinical social work is really a specialty in the field. And so we have on our various teams a combination of clinicians, peers, individuals with lived experience, social worker 3s who have more like bachelor's level education and some experience, as well as our licensed clinical staff. And so we have a different combination of that for the different teams that are responding out. Here are the public-facing numbers that we're really pushing out and calling any of these lines. They serve a little bit different purpose. So the access line is really for individuals who are not necessarily in a crisis, but who are just wanting to get connected to services in the community, behavioral health services in the community. The community crisis line, the Seneca line, and the 988 line calls to those lines, any of those 3 lines, On the back end, we're figuring it out and trying to provide some support to folks over the phone. And then if a mobile crisis response is needed, we're able to dispatch out that resource. And then just in closing, I did want to use this opportunity to ask a question of this group. I don't know if there is an interest or a need in some additional training for fire and EMS staff, but mental health first aid does have curriculum specially geared towards fire and EMS communities and staff, and it's like a one-day training, and we do have individuals within our behavioral health team that have certification and could recertify in order to be able to partner with you all if this is of interest. So I would just be really interested to hear if anybody has any thoughts on that. And with that, thank you very much.
Thank you, and I'll start with a comment to your question regarding fire and EMS support. I would definitely say in South County, we would be interested in that. There is a need for that. And I'd also like to throw out to you as well as the rest of the group. What about the patients that, or the individuals that we interact with that fall somewhere in between a crisis and needing help? So more along the lines of social services, and we've run into this issue in our jurisdiction many times where we have, pardon the politically incorrect terminology, but a frequent flyer who really needs to be plugged in to something through social services, but it's very difficult to have like that point of contact to make that happen. And I don't know if other jurisdictions experience that as well, but it doesn't sound like your program is appropriate for that. And if it's not, is there any discussion on how to integrate something like that and grow it? Because that really puts a toll on our system.
So just a clarifying question, if I can. Social services, like what types of social services supports are they needing? Like connection to benefits or housing or food?
Probably more like in-home healthcare. We get a lot of people that are need lift assist or some type of an assistance like that, or it may be a combination with some alcohol or drug abuse in there as well. But we're going out there 7-8 times a week, sometimes 3-4 times a day.
So in the community, in sort of the voluntary outpatient services realm, there is a need for folks to be receptive to the services and support. So if it's not rising to that level of, the 5150 involuntary hold where there's dangerousness, folks can refuse treatment and refuse services. Having said that, if there's individuals that you're coming across pretty regularly, the frequent flyer, familiar faces type of things, behavioral health can always receive information and then look into things on our end in terms of, are they connected to our system in some way? Because oftentimes what I've seen in the past is maybe if some of these individuals are already open and connected to our services, their treatment teams don't necessarily know that you all are getting all these regular calls. So there's a little bit of a disconnect in our system. So you can feel free to always reach out to us, and we might not be able to share information, but we can always look into it on our end and see if there's anything that we could do.
I have a question that's peripherally related to what the chief just asked. It would be mostly in your protocols. If you can be dispatched, your teams can be dispatched without a 911 dispatch. Is there a means whereby 911 and or the agencies of jurisdiction, the fire and law jurisdictions are made aware of that dispatch. So they're not blindsided in the event something went sideways.
Yeah, so I mean, we have staff out in the community all the time doing home visits, responding to individuals, doing welfare checks, and we don't necessarily call 911 to let them know we're going out to one of our clients' homes to do a welfare check based on a call we got from a family member. So it's not in the protocols in terms of if we're doing the screening and there's no weapons or immediate safety issues being reported, the team goes out. Now, if they get out there and something is completely different than how it was presented on the phone, they might be the ones calling 911 asking for that support, but it's not in the protocols to where every time our team is going out that they would necessarily be calling 911 first.
So I'd like to add to this if I can. First and foremost, Melanie's team and emergency communications, because I think calling 911 is very confusing when we refer to us as 911. When they have an emergency, we have a process in place where they actually call 911 to let us know where they are at, and they're going to get the help that they need. Behavioral health and mobile crisis would, if they notified us all the time, that would be another resource we are tracking, which means we would end up being the dispatch agency. And all of this done through mobile crisis was done without any pre-planning with the public safety answering points. Public safety answering points got wrapped up in Assembly Bill 988, not the Assembly Bill that required Melanie or behavioral health to have mobile crisis effective December 30th of last year. So we are working as much as we can together, but separately, so that the families that want to not have law enforcement or a fire response can call behavioral health, and they're going to go out and do what they've always been doing, but now on more of a 24/7. Meanwhile, if someone calls 911 or a number related to any law or fire agency in there, they're going to get a law or fire response.
Right.
And when that responding unit says, please contact mobile crisis, we have channels to contact them, and we are working on technological ways to notify them faster and hopefully vice versa. And then I want to take it one more step. Eventually, when you call 911 in this state, we will have to triage and transfer things to 988. But until that process is much more solidified or we're ready, right now in this county, you call 911, you're going to get a 911 response. You call 988, you're going to get a triage response depending on how violent you are. So I hope that clarifies a few things.
I'm just looking for the interface between the two to make sure that there are no gaps, if you will, so. And it's a growing process.
It's a growing process, and we are discussing those challenges.
Gotcha.
So Melanie, I have several questions. First of all, I think your services are where it's at right now in terms of community health. I'm curious, what are your statistics? Are you tracking statistics in terms of volume and location? And are you looking to expand in specific places, or do you feel like you have everything, equally covered?
So yes, we track data and statistics. We're required to per our mandates, but then also to, we want to help inform continued program development. In terms of, do we have everything we need? I would say no. We're meeting our mandate in that we have mobile crisis response available 24/7. And the team, the 24/7 team is based out of Salinas. So response time, we have mandates in terms of responding within an hour in urban areas and 2 hours in more rural areas. But, we all know we live in a large geographic county. And so You know, at some point while we're meeting the requirements now, we would hope to use the data to inform continued program expansion and addition of new teams.
And my second question is, what is your coordination with the facilities? And then lastly, what are your measures of success, or what are you tracking to know that you're moving in the right direction?
So in terms of coordination with facilities, can you clarify by which facilities you're referring to?
Both acute and, well, I mean, here's a good question. Do you go to ECFs?
So in terms of our state mandate, mobile crisis units are not supposed to be responding to, for example, hospitals or the, you know, more 24/7 facilities that should have protocols in place to handle their own crises. We do respond to other community, like boarding care homes, residential care facilities. You know, we will respond to our contracted providers and things within the county. So we have the mandate, and then we have sort of mobiles there to respond to uncontained crises in the community. So not necessarily in different facilities.
I guess specifically my question about facilities, do you work with the inpatient facilities where you probably have shared clients to know that you're working in the same direction for the clients?
In terms of inpatient facilities, like inpatient psychiatric facilities at like
Yes.
Trump and Natividad?
Yes.
Yes, so we're not going to respond to the hospital to those folks, but we're in the same electronic medical record for like behavioral health, and then we do coordinate with the hospitals, and so they are referring folks to us for follow-up care, so we're aware. So there is sort of that continuity of care. Yes.
So my big question, what are your measures for success?
So, you know, really mobile crisis, we're seeking to get out there sooner rather than later, try to help folks stabilize in the community as much as possible, connect to natural supports and resources that they need to stabilize in the community, and reduce the involuntary hospitalizations when that is not appropriate. I mean, at times, people do need to go to the hospital, and we want to facilitate that in a very supportive and trauma-informed way as much as possible. But we do want to reduce the involuntary holds that are being put in place when, you know, because there's nothing else to do, you know, so we want to try and intervene and come up with safety plans and supports and help folks get connected to resources so that they can stay in the least restrictive environment in the community and hopefully out of jails and out of hospital ERs as much as possible.
And actually, this was my last question. I just, do your staff write 5150s?
Yes, all of our teams are able to write involuntary holds, yes.
Thank you.
Thank you.
Any other questions? That was a good presentation. Melanie and Deborah, we thank you very much, and I guess we should think about maybe in a year coming back and having a follow-up and see what's working and what you've changed.
Sure, and I'd be happy to, if there's an interest from this committee, I'd be happy to at that time come back and share, you know, some data and data points. And anyway, Deborah has my contact information. If there's other questions, I'm also happy to get a copy of the PowerPoint to her to distribute.
Very good, thank you.
Thank
Okay.
you.
Moving on, was there a comment? Nope, guess I just heard something.
No, I guess I should throw in there that we had previously released some guidance related to interactions with the behavioral health crisis team. We received some subsequent information from Melanie and her team that related to their ability to only respond alongside or at the request of agencies with MOUs in place with the Behavioral Health Bureau. So we are working to update that guidance and we'll be issuing a new memo with updated guidance soon.
So are you saying that the agency or city has to have an MOU in place with you to receive the services? Is that?
Not with us, with the Behavioral Health Bureau. So Melanie, do you mind speaking to that a little bit?
Sure, yes. Back in 2015, when we started mobile crisis services in the county, we engaged with law enforcement throughout the county and developed our MOU. Actually, we amended an existing MOU that we have in place for our crisis negotiation team already and added this service to that. And so we have an existing MOU with law enforcement agencies in the county for mobile crisis services. And then we have the additional MOU in place now for the City of Salinas pilot program, where we would respond to not only law enforcement, but requests from fire as well. And so that's how we're operating right now.
Thank you. Okay. Anything else? Okay. Moving on to approval of past EMCC meeting minutes, and there are copies available if anybody needs one.
Move approval of the February 14th, 2024 minutes.
I'm so glad you're here, but I had to do this last night. I seconded.
All right. So, let's see. Sam Clemic.
Aye.
Chief Lamborg,
Aye.
Harry Robbins.
Aye.
Jody Schaefer,
Hi.
Paul Wood, Carla Spencer,
Hi.
John Anthony,
Abstain. Plan special meetings when I'm on vacation. I can't help.
Mike Esslinger,
I.
Chris Borkin.
Aye.
Perfect. Thank you.
Okay, EMS Medical Director report.
Thank you, Chief. So there's a few items we just completed our CCC meeting, and so there's a few items that came up, some of which will be addressed here. We talked about health data exchange implementation, and that's on the agenda for EMCC, so I won't speak further about that. Steve gave us a 2024 policy protocol review cycle update, and we received endorsement from CCC for the 2024 policy and protocol changes that will go into effect this summer. We also talked about behavioral health community crisis services, which we just heard about, and we received updates on the buprenorphine program. Happy to address that further if this committee is interested in a few changes that are on the horizon for that program. But essentially, we're looking to we're reviewing the option of making a few changes to the way we communicate with base hospitals and some of the exclusion criteria. 2025 policy and protocol review cycle is right around the corner. As we finish with one, we begin with the next. And so we'll be moving into that within the next few months. And we also had a robust and lively discussion regarding Monterey County EMS System Policy 6180, which pertains to electronic patient care records and the requirement to complete and submit those records within an hour of the completion of the call. Those were some of the major items of discussion. I'm happy to answer any questions or get into further details if this committee would like to hear any of those.
Seeing none, thank you. EMS Director Operations.
The Ops Committee has not met, and so there's no report, but I can take the next one. the EMS agency report. That is a director's report in your packet. This report is rather short compared to some of the other ones, not because we are not active, but just because a lot of our focus right now is in, RFP, HDE, and those have been their own agenda items on this agenda. But we did want to just bring you updates on some legislation that some recent changes, and those are on the staff report. And also we wanted to add an explanation as to more clarification, because we had to reschedule the meeting in January and moved it to February. But there's a new requirement placed on entities that we have to make our website accessible for the visually impaired, and also for translation or interpreting services of materials for non-English speakers. And the requirement came to us when we had questions and needed clarification on those things. That's what resulted in the rescheduling of the January meeting. So wanted to just provide that additional information to you as to why we had to do that, and why you'll see that now on our agendas. And you'll see that on when you go on our website, that now there's that option to have that materials accessible. In the future, I want to provide with some highlights of bills that are in the works that affect EMS. I will not bore you with all the details, but just things that I think that this group would be interested in. They really have major impacts on EMS. I will start bringing those to you. And then you'll hear more from me as on some of the other agenda items.
Thank you.
Thank you.
Mohawk, Deborah.
Yes, so it's been a busy past couple months, an upcoming month for the Mohawk program. There have been a wide number of various tabletop exercises or activities that we've been participating in. We went up to Berkeley in February to participate in a tabletop exercise related to regional response and coordination, which is a great experience, and some more information on large-scale incidents that would impact those of us throughout Region 2. Also participated in an educational presentation from Cal OES related to the nuclear preparedness program, and some upcoming tabletop exercises that will be taking place primarily in San Luis Obispo County related to their nuclear power plant. And we're sort of included in the, for lack of a better word, catchment area or potential impact zone for that. So it's important for us to be aware of that. We also have an upcoming pediatric surge tabletop exercise that's virtual that we'll be participating in. And then probably the biggest item is that the Mohawk was activated for the storms in early February and staffed the position within the EOC. It was a little different role for us, which was kind of interesting to work on, in that it wasn't so much focused on the hospitals and EMS who weren't as impacted by those particular set of storms, but we did a lot of work with the skilled nursing facilities who were in the area of outages, including some daily, multiple times a day communication with the impacted facilities, helping them with some of the needs. Many of them are well prepared with generators for their SNF sides, but had some other needs in their assisted living or more independent living scenarios. So we were able to help get some generators, some blankets and things like that to help those facilities during the outages. And that response led to recognition of some shortcomings as far as knowledge of sort of when to notify the Mohawk, how to pass along information, how to communicate and update the Mohawk, and how to kind of present those needs that they identify as they're working through things. So we're working on putting together a presentation for the Healthcare Coalition for Monterey and San Benito County related to Mohawk activation and communication. So that'll be taking place next week. That's it, but happy to answer any questions.
Thank you. Moving on to EMS system performance metrics, communication, testing. Kimberly, and actually it's going to be the Kimberly show for a little
That's right.
bit here.
It's gonna be the Kimberly show for a minute. Okay, good morning, everyone. So first we have the 800 megahertz and ReadyNet. Both 800 megahertz testing and ReadyNet drill results are included in your agenda packet. I don't have anything specific to report, but I'm happy to answer any questions, kind of status quo on the drills and testing. Any questions on those? Okay, I'll move on to ambulance provider contract compliance. So again, in your agenda packet, there is the PowerPoint that goes over response time compliance for all zones and priorities. So to summarize, AMR met or exceeded 90% compliance for all reportable zones and priorities. And I'd like to also point out that AMR has met or exceeded 90% in all zones and priorities since September of 2023. So that's remarkable. Also, with MPDS, the total was 80% of calls were EMD'd up until they could no longer be EMD'd. So we sort them out by if they have a determinant code or if the fire department or the ambulance arrive, there's a code or an exit code that they use, which is help arrive. So they EMD'd the call up until they could no EMD it any longer. So this was the highest month we've ever seen. So it was a total of 80%. So 78% of calls had a determinant code and only 2% had help arrived. Any questions on contract compliance or NPDS? Okay, I'm going to go into the fire other provider or fire-based ambulance report. Again, this is in your agenda packet. There's quite a few charts because we splice it out by overall within their zone and then outside of their zone. So I'm just going to go over the overall, and this is going to be for all 2023, January through December. So for Carmel Fire Ambulance responded to 1,101 calls with an average of 90th percentile time of 11 minutes and 52 seconds. And their average was 92 calls per month. For Monterey County Regional Fire Ambulance, they responded to 1,151 calls with an average 90th percentile time of 16 minutes and 9 seconds for an average of 96 calls per month. Any questions on the fire other provider report? Okay, that's all. Thank you.
Moving on to old business. Item A, EMCC reappointment. Steve.
So last chance for an in-person reminder that for those who their position is expiring at the end of this cycle, which would be June 30th, we need to get a recommendation from your sponsoring organization or citizen reps, which would be Nancy, but that didn't continue. We need recommendation from your sponsoring organization that you are to continue on EMCC. If there's any updated contact information, we'll need that because we do pass that along to the board. If you want to update your bio, resume, whatever, we also need that, and we'll get that sent off to the board. So as we discussed at the last meeting, please get this to us by April 30th, so we have adequate time to get it to the board, because there is a process to get it to the board, have the board put you on the committee, and then for you to finish your part of it, which would be the oath of office and other items that need to be in place. So you're all ready to go by July when we have our next meeting after your appointment. Any questions about it? All right, well, thank you.
EMS ordinance revision. Deborah.
Unfortunately, I don't have a large update here. We have very recently been assigned a new county council. So we've been working to bring her up to speed on the EMS related items, including the ordinance update. So we'll continue working with her and hopefully move those changes forward soon.
Health data exchange. Blake.
Blake is not here today, so I'll do the report. In your packets, there's a, excuse me, a staff memo that provides an update as to where we are with HDE. In that staff report, for SVH, we indicated that there have been some leadership changes over there, and the project kind of slowed down. We just got word from SVH yesterday or the day before yesterday, letting us know that they're back on track and they're back in motion. So we hope to be able to finalize that project with them soon. We are really at this point just looking at SVH needing to share only one essential data element, that is the physician notes. They're sharing everything else except for that. Their risk person, I believe, might be new, at least new to the project. New? Okay. And
New to the project. New
Lisa.
to the project.
New to the project, okay. And so she needed time to acclimate herself to the project, understand the requirements, understand why we are looking to share that physician notes. We have provided all the information, and we are hoping to be able to schedule a meeting with them soon, hopefully as early as next week. We also want to get a meeting with Lee Memorial just to see what the challenges there may be some challenges there, and we want to identify those so we can help move that project along. We also talked about in add-on, one of the challenges that we are trying to resolve with HDE is how to give access to the non-transport agencies to the outcome, access to the outcome information. And so we are exploring some solutions there. ESO mentioned something called EMPI. We had received some initial information from them, but it appears that it only connects with one PCR. So we're trying to see if that is the actual, the right solution for what we are looking for. So we'll provide more updates as we learn the information. The next HDE meeting is scheduled for, I believe, next week on the 19th, if I'm not, yeah, March 19th. So progress is being made. Just want everybody to keep in mind that a lot of what needs to happen is happening in the background. There's programming that has to happen from, hospital IT department working with ESO. And so we don't get to see those pieces. And going from point A to point Z, there are many steps. We working with ESO to break that down into just major milestones so that when we bring something tangible to you, so that we can tell you hospital A is in step 10 of 15, and we can see the progress better than for us to just give you a verbal report on that. ESO does have a tracking tool, but it's a massive tracking tool that tracks to a very granular level of detail. So we're condensing that in something more manageable and appropriate for these groups. Yes.
Teresa, would you characterize the progress as being past all of the policy concerns and process concerns, and now we're working on operational issues and technical issues to get this across the finish line?
With Chomp and me, they're all technical. They're programming, getting the connection. With SBH, as it relates to that, just one that, again, they're sharing all of the fields except for one, and it's the physician notes. And that's where they had questions. Lisa, their risk person, needed to understand the need for that. Is a narrative that it needs to be shared, and so they had more questions about that. That is the only one that we're trying to iron out with SVH. But with Chomp and me, there's nothing policy related. It's all just that the work that needs to happen between ESO's team and the hospital's IT department.
Teresa,
Yes.
is this group at a point where they can put any timeline benchmarks in place or anything like that as to when might be able to start seeing some of this stuff?
Well, we are seeing.
But I'm
Natividad-
talking end user, like where
Yes.
we can check it, so.
Yes, Natividad is already fully bi-directional. They're sharing everything, all of the data elements, including the physician notes, the first responders, AMR, they're all able to access that information now. There is there. SVH is connected. The information is there, except for that one field that we need to just make sure that SVH opens, and we're trying to get that meeting. Chomp and me, they're not connected. They're in the process of doing that. So each hospital, 2 hospitals are connected, 2 hospitals are not, but they're in the process. We are also working on ensuring in order for the first responders to be able to see that outcome data, the PCR in the patient record from the hospital, they need to connect. And the way of connecting those 2 records is via the chart number that the hospital issues for that patient. So there have been some challenges because those numbers are being entered manually, and sometimes they're either not entered or enter incorrectly. So we're working on cleaning that up as well. But that now we have the ability to see those records. We do. We have a number of records that are actually linking, and we're starting to troubleshoot because each hospital and the provider, they're in different places. So we would love to be able to standardize the way that patient handoff happens and how they get that chart number. It would be nice for the crews to be able to come in and know that that process is the same regardless of which hospital they go to. But each hospital has a different process. If the hospitals were willing to work together to standardize to the extent possible and make that easier on the crews, that would be one way to minimize the chances for error. EMPI has a way of doing that where it links a PCR with the chart, but there's a limitation to that, that it will only, my understanding, take this with a grain of salt because I'm still learning EMPI, that my understanding is that it will only link one PCR. So whichever one it links to first, that's the one that links to that chart. Right? And so what happens to the, let's say, the non-transport agents. So we want to make sure that we implement a solution that works, at least that we can resolve the majority of the problems, at least on this first round, and not create a different problem by implementing a solution. So EMPI was still in the early stages of figuring that out. ESO let us know about EMPI maybe 3 meetings ago, and we started exploring it. Does that help?
Yeah.
Okay,
that is-
it gets complicated.
You know, the ESO has their conference coming up at the beginning of April. Are you sending staff?
We sent staff each year. I actually attended maybe 2 years ago. So in the works, we've made progress since September. From September to now, we've made the most progress when it comes to HDE that we have in years, frankly. So, but we thank everybody who has participated. We thank the hospitals. There's a lot of work that they've had to do, and we really thank them for that.
Thank you for your work on that. Ambulance RFP, Teresa, again.
Oh, me again. Thank you. Yes, we've been very active with the RFP. Just as a reminder, during the February meeting, we brought to you the results of the public feedback that was received through the public comment and the many meetings that we conducted for the RFP. And we also conducted a meeting here at MCC. We presented at the Fire Chiefs Association, gathered more information, and then we held a number of public meetings. We received close to 170 comments. I'm going to say 167 is the number that sticks in my head. And we then took a look at all of those. We posted them on our website. I think we distributed them as well. And then we grouped them in areas of focus of topics, just to see where are the concerns. So out of those, 33 comments had to do with interfacility transports. That's the one that got the highest number of comments. That was 20% of all the comments were related to IoTs. And then there were other areas. For example, I just made myself a note. Clinical requirements, dispatch response times, and priorities. About 5% of the comments were related to those topics. And then it went down the line. So the area of they had more attention, of course, was interfacility transfers. When we reviewed the comments, then we started seeing that we are looking at conflicting feedback, if you will. On the one side, and this is stuff that we reviewed at the February meeting. So just as a reminder, on the one hand, we have comments that say, we want the provider to continue to be responsible for all IFTs, and then we want more. We want them here. We want them here when we request them. We want them at the level that we request them. And then on the other side, the opposite of that says this transports don't even belong in the 911 contract. There should be a separate contract or multiple contracts for those services. it is not fair to put the burden on the ambulance provider. So we are finding ourselves in the middle of two conflicting viewpoints and what to do. Of course, first and foremost, our priority is to meet the needs of the patient and to balance the needs of the system, the hospitals, fire agencies, the ambulance provider, in others. So we developed a number of models to see if we could find solutions to that. But what we do know is that keeping, and we've been saying this all along, that keeping status quo or even adding to the status quo may not be sustainable. We've seen that. We've had 2 other RFPs that were not successful. And then on the opposite end of that is taking IFTs out of the 911 contract also has its own implications. And then now we're like, if we find a way to accommodate the request of one group, then we're not meeting the request of another. And so where do we find ourselves? So we have put together a number of scenarios. We have been discussing those, trying to see if we can find the sweet spot, if you will. Everything from the current model and what does it mean to keep the current model? What does it mean to add to it? And what does it mean to take IFTs completely out of the 911 contract? So that's where we are. We have been also just doing revisions. As I said, we took all the comments and we grouped them into topics. So we've taken each of those. Clinical standards was one of the topics that got a lot of questions, and we've done some revisions. We are consulting with the state, with a consultant that is providing the technical assistance. We are looking at what others are doing around the state. A lot of comments related to the workforce as well. We're looking to see what is it that we can do there, because the language that we have in the draft scope of work is the language that was approved by county council. There's certain things that they have that they advised us on as far as the language that we can have in the RFP. But we will continue to do that. And then, of course, finalize, get the final approval from council and get that off to the state for their own review and approval before we can release it. So that is the update related to the RFP. I'm happy to answer any questions.
Teresa, do you have a timeline for any revised drafts?
Yes, the revised draft should be coming up in the next 3 weeks.
And along those lines, I think it would be helpful, just so we know where this is at. Like if you had kind of like a schedule, this happens at this time, this happens at that time, so.
Yeah, and the timeline started to be, we started to revise it because we needed to go back to and deal with this monster of an issue, which is the IFDs. So, but yes, my apologies, it's been just a crazy beginning of 2024 for me. So it was just a lack of time. And the timeline is difficult. Is difficult because there are so many variables right now that it's hard to put a clear timeline on parts of the project. But we'll definitely bring something by the next meeting.
Thank you.
Actually, one follow-up question to that, Teresa. And when you talk about distilling down the commentary in the research you're doing statewide and looking at other things, am I hearing that you make those judgments in a revised draft RFPs? Are we going to have some sort of opportunity to look at some of the things you're looking at as it goes into a draft options? I guess more open discussion about what some of the options are to address the issues that you're talking about. And I say that just from the standpoint is that with the representation that sits not just in this room, but all the other committees, is that, obviously the people providing the commentary, if they understand what some of the issues are on either sides of the fence, perhaps we can help iron those out and come to a compromise that that fits into, the legal requirements that we're looking at, the state requirements we're looking at. In other words, maybe save you a little bit of legwork if some of the folks that are bringing up the comments are the ones to help you solve the problem.
Yeah, well, and when it comes to the biggest issue, which is IFTs, we have been reaching out to the hospitals because they're really the ones that are directly affected by whatever we do with IFTs. The other ones with clinical, like the clinical standards that got, the highest number of comments after that, it was more clarification on the standards and needing to understand the compliance. Was this a compliance issue? I think that we needed to fine tune our language. Response times, there were some questions about response and they were just needed clarification. The one that we needed to look at a little more carefully was the priorities. I think that once we got the feedback back and we went back to look at it, it was also more about clarification about the difference between priority 4, 6, and 7, I think it was. So we needed to just provide those clarifications. Questions about rate adjustment, the methodology for rate adjustment. And for that, we have a financial analyst that we're working with so that they can help us develop the right formula. The current formula, we find, we made a revision. We actually started putting a different formula in the new, in the draft RFP. And the comments that we got is that it would not, from the provider's perspective, that it would not keep up with the actual changing cost. So we threw that question back to the financial analyst. The question about maps, we were revising those. We needed to work with our GIS team. Really the big,
I wasn't necessarily asking you to list all of it, but I'm just offering, like on behalf of the Fire Chiefs Association, from our perspective, anywhere that we can help and have those discussions where we need to understand where some of these other issues lie, that maybe there's a compromise to be made, or there's an understanding that needs to be come to. Where we know, where we have the information about, what are the options? What are we thinking about
we
here?
appreciate that offer.
I don't mean to cut you up, but I want to add to that because at the last meeting, you'd expressed that there were some challenges in the feedback that you'd received, that it was not specific enough. So, and speaking primarily with, our group, I think having that ability and building that time in to maybe get that review is not necessarily like a do-over, but it is a chance to maybe address some of those things that if they weren't specific enough, that they could then, come up to the top and we can find out if they can be discussed or they can be a modification. So that's a great point.
Yeah. And we did the SWOT analysis in the summertime. And then we released the draft scope of work, not the entire RFP, but just the scope of work to solicit that input. But in some cases, what, some of the comments had to do with that. It's like, we'll be innovative. We want innovation. How? That was the time to tell us how. There was more direct feedback when it came to CCT, for example. It's like they recognize there's a low volume, but they want CCT regardless, right? So that was very specific. So that's what I meant. The flexibilities, like make this contract flexible. There are some things that we can't deliver. We can't deliver a flexible contract. We can only deliver the flexibility that the state would allow us to in the county, county council. So it's not about that. Those areas, for example, may not be necessarily about the feedback that we get, but just more as understanding the limitations. These contracts by nature are not flexible. They may be starting to be. We're working with the state just to see how flexible we can be when it comes to the RFP. For example, in the past, we had to prescribe the services. In a more recent time, with changes in the leadership and other changes at the state level, now we can actually say to the providers, tell us how you will propose. That question we couldn't ask before. But so what we want to get that feedback is that maybe a better way for us to set parameters in that RFP, they say, this is what we're looking for. How do you propose to provide it? Instead of saying, provide us this. So those are the things that we're looking at. Again, I think we're doing that, reaching out with the hottest issue that we have, which is the IFTs. And trying to come up with a different model just to see what are we're gonna have to make compromises when it comes to IFTs. And so trying to work with the hospitals that are the ones directly, not responsible, but affected by any changes that we make to the way things are today, and seeking that feedback. But yes, and we reach out. We do reach out to get help, you know, in the areas where we can. And again, we have to be careful as we approach the now when we start to approach the more formal part of the RFP. When in this phase, yeah, we're still connected. We're doing that. We're providing you reports, and you know, you can voice your opinion. You can share your ideas even in this forum. The perfect forum, because it is public, and that is how county council wants us to seek the input mostly in a public forum.
If I could just mention real
Sorry,
quick before he speaks, is that Christy Soboleski over at Chomp and myself are leading a hospital council with all 3 hospitals. And so we're looking at IFTs, and we're looking at different companies that may be able to provide that service, so that as the hospital group, we can give a recommendation to the EMS agency when it comes to IFTs, behavioral health and CCT. So it was very helpful getting the presentation with sort of some of the options. I think there were about 6 options. And so we're working on that. I actually have my assistant putting together this analysis we did with a couple agencies. And so we're going to be meeting again next week with the hospital representatives from Natividad, Chomp, and SVH, and then we'll hopefully then be able to provide a recommendation. Dr. Kolinsky is very much involved, Dr. Greenson as well, and so yeah, so we're working on that in the outside.
We have a hand raised, Clay, on Zoom.
Hello, good morning, y'all. How are you today?
Well, thanks.
Good. Yeah, this is Clay with ATP. Teresa, thank you for your time on going over the IFT, the RFP information. Carla as well. Good to see you too this morning. I just really wanted to kind of touch base with y'all on the RFP and the IFT and the 911 and the interfacility stuff. You know, you're talking about 2 separate types of services. You know, from a state level, yes, the 911 service should be handling the 911 calls. The IFTs, that's kind of a county by county basis on whether you want to include that as a bonus within the contract, correct? Am I mistaken by saying that?
No, I think you're right.
Okay. And the reality is the issues that y'all are experiencing in the county are current and now. And a fast forward to 2030, you know, the baby boomers are getting older. We're going to have a huge influx of IFTs that are going to be happening. They're already happening now, but it's going to get busier. And we're talking about a good 20-year span of baby boomers. So if y'all are already having issues with these IFTs and AMR, which is one of the largest ambulance providers in the country, whoever takes over the RFP and provides that 911 service, I don't know if they're going to actually be able to provide any better service than AMR is already providing. And we got to keep this in perspective, because at the end of the day, patient care is what this is about. Separating the IFT from the 911 contract, it works. You don't have to have an IFT company contract with the county to provide those services. They nearly have to just contract with the hospitals in which they're working with, so that everyone's on the same page as to what rates are going to be paid, what's expected, those sort of things. And it does bring competition into the county. It will bring additional services. It will bring additional jobs. So it's a good benefit for the community and for patient care all around. So I just want to make sure that we keep that in perspective.
Thank you.
Absolutely.
Good discussion. Anything else? All right, EMS annual report. Or EMCC annual report, Steve.
So, in your packet, you have a copy of the annual report that, you guys put out last year and did some research on Levinson websites to see what annual reports their EMCCs did, and it was really quite eye-opening. I found some LEMSs did not even have an EMCC, at least nothing that was even remotely referenced on their website. And I found two EMCC annual reports, one from Cocoa County and one from Los Angeles County. And as you could see, I included them in your packet. They're a couple years old. So, I commend this group for getting started on doing regular annual reports. It looks like you're doing something more than most, which is unfortunate because in the health and safety code, the EMCC is actually, it uses the word shall provide an annual report. So we're meeting that requirement. We're moving forward. How we do that, how you guys do that is really the question. So if you look at the LA County, I want to put that on the table first. They seem to have a little bit greater charter from their Board of Supervisors, and you'll see that they've integrated into a few other things. If you look at the Cocoa County report, it's very similar to what we put out in 2020 or for 2022. That said, what I've just handed out is something I created after we created the packet for EMCC because we have to do that fairly early. In the 2022 annual report, the main topics, there were 7 of them, and we filled in, information under those. To help with your work, I went back through our agendas for EMCC in 2023, and I've listed 13 main topics that we really did some work on. You'll see, we didn't talk about RFP. We've got the scope of work in there. So those are the topics that we recommend. How you guys approach that is up to you. I'm happy to have you guys work on sections, different areas, one person do it, receive information, put it together so it has a common unified voice. But at this point, really, this is your baby to push forward and grow and create a report that you're proud to show to the Board of Supervisors. So at this point, just, we had some good discussion last time. At this point, really just looking for direction, how we can support you guys with the annual report.
What I think I'll start, and I think last year was the first year, it was basically it was the EMSA staff that brought it to us saying that this is a requirement. And we got on board, and actually the staff got on board and took care of it, which is good and appropriate. I'm a little confused as I'm hearing you, Steve, with like what the expectation is in regards to like EMCC members taking care of this. I mean, are you suggesting that here you go, here's the report, you do it, you deliver it to the County Board of Supervisors? Are you saying that, are we just bringing it here for discussion and determining what the critical points that we want to put in the report are, and then EMSA staff puts that together? Or I guess third option, just in general, listening to this, like, well, haven't been doing it, very few are doing it. Do we even need to do it at all? So
It is a
It
requirement.
it is a requirement. Health and Safety Code does use the word shall create a report. It also prescribes some of the items that are to be addressed in the report. Clearly a report on what the activities of the committee are doing, the areas within the EMS system that are being reviewed. Those are to be included in the report. It talks about a review and report on first aid activities, first aid training in the county, which honestly, this group, I don't expect to really have a great handle on it. The agency doesn't have a handle on it because we don't regulate it. But that's one of the things that are listed as a shall report on and review.
Is
So-
there a timeline when it's due? Like,
It's
is it?
due in July
It's due.
to the Board
okay.
of Supervisors. Now, let me offer this, because last time Deborah put it together, brought it to the committee for review, and we submitted, because it was the first one we were doing.
Yeah.
So Steve has identified some of the key discussion topics that this body discussed last year. We could put together the report that way for your review, and then maybe the task may not be so daunting for the committee, and you can add or change as you wish, but we can give you at least a starting point of the activities that we know that primarily is actions that this committee could, approval of the buprenorphine, endorsement of the buprenorphine program, for example. The pulse point, I think there were several items here that endorsed by this committee. So those, I think that could be definitely worth highlighting on a report. That shows the efforts to improve the system. And then turn it over to the chair to see to add to it if you wish, or change as you wish. Would that work for you, Chief?
Harry has a comment.
What I'm hearing here, Steve, is that this report should be where we've been, where we are now, what the results are, and where we're going, focusing on certain areas. It should be succinct, small bullet paragraphs addressing each one, if you will. And to me, the emphasis and the expertise rests with staff to put this together in a draft format to bring it back and be approved. I don't think any of us have the detailed knowledge in all the areas to write this from scratch. So I would recommend we do that. I think that really sums up what Sarisa said, and move forward.
Where the access to the data
Yes.
that is gonna drive that.
So when I was looking at last year's report and the sample reports that you had from the other counties, I see no reason to change the format that we currently use. It's lovely. And a lot of it, in terms of who's on the membership and stuff, that should be pretty easy to fill in. I went back and looked at our agenda items over the last year. There really weren't that many new agenda items or action items.
Exactly.
To me, the biggest deal was that we changed the structure. But, things like the buprenorphine, the ET3 that we reviewed and of course, looking at the RFP and participating in the SWOT. But other than, I like what Harry said, where we've been, what we know, where we're going. I'm not even sure where we're going other than to look at, I guess it's the health data exchange and the RFP that's it. I mean, I don't know what else
These are big ones right now.
Yeah. I mean,
As I said,
I think.
why get complicated when you need to get the
There's
big deals done?
You should
Yeah.
see our list of pending items that we need to start bringing, but until we get,
Those two done, why are we talking about the little stuff? And
Yeah.
something else will come up, expand, I actually after today, expanding the mobile crisis team.
Yeah.
Let's make it simple.
and play the KISS principle.
I agree with that. But the only difference I saw in the Contra Costa one was they did have a section on like objectives for the next year.
That's
I
where
think-
we're going.
Yeah, and
Right.
I think, in the future, I think we're still putting this report together and building it out. I think like in future years, past the RFP, some of these other major things, and we do include in the meeting an agenda item in preparation for the report, like a goal setting session, and then we can.
Yeah, one of my goals has been to do a strategic planning with internally with the agency, with this committee and then system-wide. I have reached out to the folks within the health department. They have people who do that, our PEP team. But Krista left, and so they're in transition there. And then, you know, we're always jumping from fire to fire. But yeah, that would be a way to do that, for us to do a mini strategic session, bring somebody, even if we have to look at bringing a consultant just for one of the meetings, do it in March, do it in May. And that way the report is ready when it's due in July and sent to the board. But yeah, it is good to focus. I mean, we're cleaning up a lot of things in the system. The agency looking internally, I mean, that's one of the reasons why we brought that requirement to you, that we were looking at the requirements. Is like, there's a requirement for this report. So we brought it to you, so.
In this capacity of the committee, the most essential thing is when you address the supervisor or whomever, tell them where you're going, strategic plan, whatever have you, whatever you want to call it. They've got to know where we're going, what our focus is, and what our goals and objectives are. And whatever you want to label that, that's where we're going.
Yeah.
And that should be the bottom line of any report of this nature. To me, it's fundamental to the committee supervisorial rules that we're dealing with here. They're the people who are going to read it, and it should be simple, succinct. Here's where we're going. Bing, bing, bing. Bullet, bullet, bullet.
And the rest of the information is what we did, which is very simple. We know what our agenda items
Exactly,
are.
exactly.
We're not doing anything outside of what we do here at the meeting, so there's
Yeah,
no
and it goes
secrets.
hand in hand with the EMS annual report. You know, they go together.
Yeah.
And in that, we do exactly what you said, Harry, that we established the goals for the year. So they kind of talk to each other.
If you put yourself in the shoes of the person who's going to review it, what do they want to see? Do they want a bunch of milk pap? No, they want to see where you're going, what you've done, where you're going, and are you focused? That's the way to do it.
Okay, if I could ask one question, because it looks like, you know, one of the reasons I presented this, I'm gonna go back up a little. One of the reasons I presented the way I did is this is EMCC's report. I did not want to come in and say, hey, we're gonna write it for you, just as we did last year. We did that as, you know, to help get it launched. But, you know, if you guys would like us to continue to frame it, put it together to then have you guys work on it, happy to do that. Just want to come in and say, here's what the agency's doing, because it's your report. Happy to let you guys, you know, put it together how you want. Now, with that said, looking at, we've got 13 items. I can't, you know, put a lot of effort into every single one of them. Are there a couple of them that you'd really like to highlight in the report?
To me, the structure change was huge. The SWOT analysis. The ET3 came and went. That's important to memorialize.
Northern is a big one.
Yeah.
Because it's.
Okay, I can make sure we pay particular attention to those and really highlight those as accomplishments. Okay, thank you.
Steve, I'd like to stress one thing. Going back to my former career, we had a thing on staffs called a point paper. This is the problem, these are the options, and this is the recommendation. Any background there, 1 page, no more. This should be a short, simple, bullet type approach. It should not be a 27-page, Dead Sea Scroll. Okay, keep it simple, keep it succinct.
Okay, so are you looking for a motion or?
Now, this is just discussion so we can move forward.
Okay, so just to sum up with everybody to ensure we're all on the same page, is that basically our direction to staff is to essentially utilize the same format that you used in the past. And then also consider adding some where we plan to be a year from now.
Does this have to come back for an action item in May? Is that, if it looks like that, do we bring back the report and it's an action item that we say?
We'll bring it back as an action item. We'll see if, I mean, if you guys like it the way it is, then you could take action. Otherwise, we definitely need it by
Can we make edits
July.
in May that we then say based on these edits, we approve?
If it's that close, sure. I don't think we will be, because I really, based on the discussion here, I expect that it'll get, a lot more, there'll be more of a draft. Which you guys will be ready for July, but I'm gonna do everything I can to make it something you guys are very happy with for May. Maybe move it forward, but it'll be an action item.
So draft for May. And if any changes or major changes are needed, they could be brought in July and still meet the deadline, right?
Or it could be approved with these changes.
Right, it'll be somewhere in there, but we'll do everything we can to have it, something you guys like, minimal changes.
Steve, can we get it to this committee with, enough time for them to review it
Oh, has
prior
to.
to the meeting so that we can come in and.
Because the meeting in May is an early meeting, I believe it's the 8th.
Mhm.
So, yeah, we'd have to get this to you middle of April to give you guys a couple weeks to look at it, and then. So, yeah, that's how I would envision is middle of April having the draft to you guys.
Will the other committees see it as well in case they have some insight we don't, or not?
That wasn't a plan.
Yeah, that
because
wasn't-
It is an EMPC.
Okay,
Yeah.
no worries.
Okay, anything else?
As we get better, we can make more changes.
EMS annual report, Deborah.
Yeah, so the EMS agency also has its own annual report for Board of Supervisors to put together. The team has started drafting language for the updates and additions to the 2023 annual report. Our plan, much like with your report, is to get that distributed out to you a couple weeks in advance, so you have some time to review it before the May 8th meeting. And then bring a presentation on it to you guys at the May meeting, and then take it to the Board of Supervisors during the week of May 20th, which coincides with EMS week and the proclamation recognizing EMS week as well.
Any questions? Okay, new business showing none. Announcements for good of the order. Anybody have any?
I have one issue, and this is more of a form of a reminder. Back during our response to COVID, we had some discussions with respect to some aspects of the county's response. Most of them were fielded by then the emergency services manager, like Jerry Malise. Right, okay. And we were assured that there would be a after-action review of the COVID response, particularly with respect to public information. I'll withhold my comments on what I think the quality of public information during that event was. But it has not occurred to my knowledge. And so we're still awaiting that event or input or whatever happened. So I'd like to see that happen.
And I could just speak, we did meet they engaged an outside firm. I know, because I was operations chief for our hospital. We did participate in some questions, thoughts and things, but I haven't seen anything that came out of that.
Oh, nor have I.
And that was maybe a couple of months, maybe before the holidays.
I've reached out to I've reached out to Kelsey at DEM and to ask if there's a report, review of
I don't know who's coordinated it.
Yeah.
It could have been the health department and their aspects of it. But the impression we were left with at the time was that OES, now DEM, was going to coordinate that as the overall incident commander for the operational area. I think it's critical. Being trained as a public information officer and what have you, it's absolutely critical that we look at that in a very objective perspective and apply the lessons learned.
Yeah, so anyways, I have reached out, but not heard back, so
Thank you.
I'll continue to reach out.
All right, thank you.
I would add that the health department did hire a consultant as well to work on these issues. So they completed quite a few surveys. That may have been one that you participated in, Carla. The EMS agency Mohawk program was included in those. They've released an initial draft of that. They were working on finalizing and assigning some tasks and timelines related to those tasks. But at least for the health department piece, I would imagine that would be forthcoming.
The health department is an integral part, but the overall responsibility in my mind rests with the operational area as the incident commander.
Well,
So can-
Steve can follow up on it.
Or would you, like a memo on behalf of the EMCC going?
No, I think Steve following up and give us some feedback at the next meeting. Where we stand and go from there.
Okay, excellent. Thank you. It's anything else? Nope. Another good meeting. It was long, but a lot of interaction. Good stuff. Thank you, everyone. Meeting adjourned. Thank you.